Hello, everyone. I thank a lot for the invitation for this presentation in this nice Congress of Argentina. As much as I love Argentina and the wine, it's too bad that I can't be there right now because of this pandemic thing. So let's start with the presentation. Okay. All right, thank you. So can-directional leads improved DBS. Can-directional leads improve DBS outcome in Parkinson's disease if this is or is not of clinical relevance. En claro, en español, el rol de la DBS direccional por la optimización del control de síntomas de la enfermedad de Parkinson. I have no conflicts of interest to present this data. So DBS has been for at least 4 decades applied in patients with Parkinson's disease has reached the highest clinical quality evidence that a technique in neurosurgery can reach, and now it's established method for the treatment of also other movement disorders as dystonia, essential tremor, symptomatic tremor, chorea, but also psychiatric disease and epilepsy and other types of conditions. DBS has proven an impact in quality of life with DBS, with SDN stimulation, but also with GPI stimulation. This is a nice work that shows the improvement in quality of life and in functional improvement, also in quality of life in 12 months, but also in 60 months. That has some loss, but it's very small, and we keep the improvement quality of life of those patients a long time. This is a quite important issue. But it's a matter of fact that, of course, we have always wanted to improve all the techniques that we want to apply. Some loss of this quality of life, it's due to progression of the disease, but also by induced side effects of stimulation that we know now it is also of clinical relevance. Everything that we know, all the data that we know on DBS right now, mostly, is made from actual ring stimulation. So those are this is some historical images that show that how DBS has improved, how the leads have improved since the beginning. But all those leads have in common that we can only steer electrical field along the axis of the electrode, either monopolar or bipolar, but we have to choose between the 4 contacts or the 8 contacts along the line, along the axis of the electrode. So this is a characteristic of all electrodes like that have been constructed until recently. And now we can also show some other improvement in the next slides. So some of the anatomy in this region. So the STN and the thalamic region is very complicated region. When stimulation is done properly, there is a reduction of rigidity, akinesia, and tremor, but also possibility of have side effects. So the side effects, as we have mentioned before, are related to some of the decrement in quality of life of those patients. So if the patient has tetanic muscle contraction, or dysarthrophonia, or gaze deviation, or even dyskinesia induced by the stimulation, also affected disinhibition, hypomania, and even inhibition of levodopa effect. So this is a very important issue, and this is of very important, highest effect in clinical outcome in patients. So we have to stimulate in the right place, and we have to keep it in mind that we should not stimulate in some places, that we can evoke some side effects, induce some side effects. So not only the progression of the disease, but also induce side effects from the stimulation. This is quite important. So one of the ideas that we could improve outcome of DBS relating to the conformation of the anatomy of the, in this case, the subthalamic nucleus, was from this very nice work from the German, one of the Germans group, and this was very nice. They constructed an idea that even within the STN, you could have different outcomes relating to each simulation. So you can see that if you are in a more lateral or anterior dorsolateral region of the STN, you could induce very good outcome, while if you are in medial, posterior, inferior part of STN, the outcome is not so good. And this is of clinical relevance in this shown in this green columns, and also how this is different from the red column. So this is very important. So one of the idea is that if we could stimulate within the STN, for example, within the XTM, if we could stimulate internally, avoiding stimulation of all regions, as we have with the different, with the electrodes that we are we are using now. So the idea is that new leads have been constructed. Some of them are available in the market, some of them are not available. I would say that the two leads in your right hand side are available now in the market, and this is very interesting because we have not the 8 contacts in line, but we can have directional lead. So one lead is divided in 3 one contact is divided in 3 different contacts that can be stimulated differentially. So the idea is that you could not only steer stimulation around the along the axis of the electrode, but also along the sides of the electrode differentially. So this is new. This is a really interesting thing. However, we have no idea if this is of clinical relevance, I would say. So if you have a lead that is not optimally inserted or implanted, you could steer from the side of the lead, avoiding some of the side effects. So this is quite interesting. And also there are some side effects that you cannot identify in a clinical session of stimulation or reprogramming. So some of the side effects are built up a long time, and we sometimes don't detect this right away, and the patient is building up this side effect along with months, weeks, months, and years, and this can become a problem for the patient. So if we can steer or even test different parts of the electrode, this is quite important. So there are some studies related in the literature. The first one was from Polo in 2014, but also Contarino also in 2014. They showed that most patients benefit from the directional stimulation. This was only intraoperative studies. And also the directionality improves the therapeutic window. So avoiding side effects, putting the side effects away from the stimulation, the therapeutic stimulation. And also that directionality is somewhat consistent with anatomy. If you are close to the internal capsule, you stimulate out away from the internal capsule using directional stimulation. This will improve or will decrease stimulation of internal capsule. This is also of clinical relevance. There are some studies also saying that directional stimulating done chronically implanted patients, and this is also showed that improvement of the therapeutic window. This nice work done by the Jens Volkmann group. This study shows that there are some inequities, or there are some differences between leads with the directional stimulation and with the ring stimulation in the same patient. However, this was not done very in chronic patients. This was done in the first 15 days of post-operative period. So I guess in our experience, we can say that maybe they could have shown better differences or more steep differences between directional and non-directional if they had done this afterwards, or some months or years, or a year, 6 months or some months after the stimulation began. So this is quite important. So the conclusions in this study can, now we know that, are partial. This is another study, very nice study from the group of Denbeck and Timmerman. They also showed the same thing, or very alike, the conclusions very alike with the other groups, showing that directional, the therapeutic window is different in directional, and it's more interesting than in circular stimulation. And also the threshold for side effects is different from one technique to the other. There's also the idea that when you stimulate with directional lead, this can decrease the battery consumption. This is very nice work from Erich Pereira out of Oxford, and showing that in blue and yellow, directional or ring stimulation and directional stimulation, you can get a better directional VTA oriented to the targets that you want, spending far less battery than usual or current stimulation. Our experience by now is around 75 patients. This is patients, they respond well to levodopa. We treated patients with Parkinson's disease, well responsive to levodopa. However, not very early disease. We usually apply this to moderate to advanced Parkinson's disease patients. So all those patients had bilateral STN stimulation for at least now 48 months now, and exploring the and now we are doing the exploration of these techniques since then. We use currently magnetic resonance fused to CTs, as you can see now the different MRI sequences that we can use. Usually we use SW, also proton density, and the T2 fused to, and also the T1 with contrast, and we take different characteristics from each of the sequences to compose the final study and to to perform the surgery. So this is the STN, the sequence for the STN, and as you can see, it's very nice seeing images. We also use routinely the microelectrode recording. We think that for the STN, it brings a lot of data, a lot of inputs from the electrophysiology. It's quite important in this region. And we do usually with 3 electrodes in parallel. So unless, as you can see, the implant technique is quite it's really almost the same as in normal electrodes. So we use the images, stereotaxy images, as you see, and also microelectrode recording. But there's one difference that the surgeon has to take a look, which is how you steer the electrode during the implant. So this is suggested from the company that you should include, or you should orient your electrodes with the little marker that you have looking at the anterior part. So as you can see here, this can show you how you can orient, so you could now know where you should stimulate in. So this was the idea until some years or 2 years ago, when we started having the some problems with rotational deviation of electrodes. So we started doing not only intraoperatively, but also postoperatively X-rays. As you can see here, there can be some rotational deviation of the electrodes, as I will show you right now. So this is very nice work from Tim Dembeck and Vissa van der Walle. Very nice. They showed very nice with a lot of experience with these electrodes now, and they show that deviation can go from 0 to up to almost 120 degrees. So if you have a rotation of somewhat 90 degrees of these electrodes, everything is changed. So the idea is that you should do some study, either CT or X-rays, plain X-rays. You can do that. You can assure that with plain X-rays also. This is the technique that we use, and this is quite interesting because when you implant the electrode, there can be some rotational deviation, not deviation from the target, but rotational deviation from the electrode in its axis. So this is quite important for directional stimulation. I will present some cases that you can so you can have an idea how different can be stimulation, directional stimulation. So this is a diagram that shows patients on levodopa and off levodopa before surgery, after surgery, 1 year after surgery, and DBS plus levodopa. So you can see the improvement in UPDRS. So the idea is that if you have a good improvement, or how to measure if the improvement in these patients is good enough. So this is quite important. Maybe this is one of the ideas that we'll put a directional DBS now in evidence, So we can say, if you have, if you divide DBS, the effects of DBS over the effects of levodopa in pre-op period, you can have this index around, if it's better than or greater than 0.7 or 70%. So this is, you can relate that your surgery is working well or is optimized. So if it's not, maybe you should correct or go all with all the protocol for reevaluating your patient. So this is quite important. Every patient has a possibility to improve with DBS if they have good improvement with levodopa. And this is somewhat related, especially in patients with STN stimulation. So I show one case that the patient can be shown, and this patient was initially had the levodopa challenge test of improvement of 71%, and afterwards the patient had an improvement in DBS, improvement in clinical outcomes with DBS around 54%. So this is somewhat okay. However, what we had with directional DBS is quite different. Take a look. If you compare the initial ring DBS and directional DBS, we had the improvement even greater than we had with levodopa. So this is different. I think this might be a very important improvement for patients with Parkinson's disease. So we stimulate in one region and not stimulating other regions around the STN makes us have some improvement, really interesting improvement above that what we had with levodopa. This is another patient that has also improvement around 54% of the UPDRS-3 with levodopa, and he improved somewhat around that. So it was within the range that we had. However, he developed some freezing afterwards. So before that, he was in a wheelchair, he couldn't walk. And then he started walking, but had some freezing, still had some freezing. Is this of the disease, or this is from the stimulation? And we started doing then directional stimulation. And now we could see that some of the problems with the gait was related to DBS stimulation. So this is quite important, not only to show that patients can improve even more than in the past, but also that stimulation can induce some deficits in the patient. This is another patient I'll show you. That bilateral stimulation. This is one of the patients that had some progressive worsening of speech. So I showed tremor, I showed gait, and now I talk about speech. He had some mild speech disturbances, somewhat called stuttering, like a gagueira in Portuguese. So patient had some problems with this, and was initially implanted with normal stimulation types or regular DBS. In the beginning, he had 66% of improvement in levodopa. So he improved a lot with DBS. However, he had some worsening of speech during this time. And then we we gave him some idea that he could have this system replaced by directional stimulation. So we did this, and this is even still the same case. This is the patient this is the during the phonotherapy. So recording of the voice. So in the left you can see that the patient saying ah, and in the right you can see the patient counting 1 to 10, 1, 2, 3, 4. So the idea is that with of course you cannot say that from this image, but when you compare, this is during stimulation, ring stimulation, and then we replaced the electrodes and begin again stimulation with the directional leads. So this is quite different. So patient saying ah, the hypophonia went away, and now he could really have a good phonation for meetings and for interpersonal talking. Also, the vocalgram showed some differences in a prosody, which is very interesting because he went from a very monotonous speech to a very different tonic speech. So this is the normal. In the right, this is more close to normal, and that is that phonation that is with hypophonia and very monotonic voice, which is not normal. So this is another case that I should start finish with this presentation. This is an essential tremor patient, and this patient had very severe tremor. You can see the accelerometer of the tremor in the right hand. He had uses of propranolol and also primidone up to 700 milligram daily, and he had he even with that he punctuated very high in his scale of Antolozamarin tremor scale. So he had some difficulties with tremor, and even using very high doses of medication. So the idea is that this patient had a tremor that really problematic for his functionality and also refractory to medication. So what we did was to implant not a directional lead in this case, but a 8 contact lead from the VIM to the caudal zona incerta, regions that we know that can control very well tremor in general. So the idea then that we could have different targets, or target in a VIM and also target in CZI. So we would have 2 targets in 1 electrode. But truly, we could really have 8 targets along this axis, and even stimulation the thalamus itself, but also the pathways from the cerebellar nuclei. So this is quite important. We know that DBS for essential tremor can habituate a long time. So we propose in this publication that this could be changed a long time with very small differences in contact stimulation, different networks, even controlling the tremor, but also going away from habituation that we sometimes see in ET tremors. So this is the comparison between no stimulation in A. This is stimulation of VIM, and this is stimulation of CZI, caudal zona incerta. So, which is really interesting. Of course, the improvement with VIM stimulations was also good, but the improvement with CZI was really impressive. And the idea that you can change different stimulation parameters and you can induce tremor control, avoiding side effects and habituation, it's quite nice. So stimulation with directional leads, we think now can avoid side effects in some patients, but also can improve specific benefits. This is nice because in the past we thought, oh, if this lead is not good, not optimally placed, we should then try and correct this. And then, oh, this is not needed because of stimulation with directional leads. But this is one part of the technique. But the best part of it, if it's really well placed leads, can also improve the quality of life and functionality of those patients related to the stimulation itself. So this is very interesting thing. And also we can actually, it's known that we may be saving some battery. This is very important. And of course, with the possibilities that we can combine stimulation and field parameters and improving our patients. So in conclusion, I would say that directional stimulation is now under development. This is a new paradigm for DBS stimulation, and this is quite interesting because you can stimulate patients and you can stimulate less the target, so more focalized, and this apparently have some improvement, will give us some improvement in functionality and also in quality of life. So this is part of our group. Part of the group was included in the first directional lead implanted in Latin America in 2016. So I thank you for your attention and also for the invitation. And I stop here. Thank you very much.